Welcome back to Pomegranate Health. I'm Mika Cavazzini. This is part 2 of our series on dealing with the next pandemic. It's an examination of what public health got right in responding to COVID-19 and what we might do differently next time. We already discussed how international border closures did protect Australia before vaccines were widely distributed. On the flip side of that was the overcooked parochialism between the federated jurisdictions. We also discussed whether vaccine mandates were an acceptable onus to put on the public, or whether, instead, they squandered trust and buy-in. Most people did roll up their sleeves and get the jab, and serious adverse events fortunately impacted only a tiny fraction of vaccine recipients. However, the burden of social measures, especially the stay-at-home orders, was one that was felt by the majority of our urbanised population at some point. These resulted in measurable impacts on physical and psychological well-being that we need to consider before deciding how hard we'd go in controlling the next pandemic. In the previous episode, I said that up to 50,000 lives were spared thanks to our strict non-pharmaceutical public health interventions in the 3 years up to December 2022. That's a crude estimate from looking at the mortality rate seen across the European Union, or in less severely affected American states, which averaged around 2,800 deaths per million. Multiply through by Australia's population and that gives you a potential death toll of 74,000. Subtract from that the 13,500 deaths that actually occurred and that's how you get a possible 50,000 saved. If that sounds generous, take a look at the Burnet Institute's retrospective analysis of Melbourne's Delta wave of August 2021. This shows that without social restrictions, at least 16,000 more lives would have been lost in that one outbreak. The case fatality rate for COVID-19 started at 5% in some countries, and then dropped to as low as 2% by the second year of the pandemic. It was so transmissible because people infected with SARS-CoV-2 could be shedding virus for a few days before becoming symptomatic, if they ever did. So the true infection fatality rate would be an order of magnitude lower. By contrast, people infected with the 2002 SARS virus or the 2012 Middle East respiratory virus would be sick in bed or in hospital by the time they became contagious, so there was much less community transmission. SARS killed 15% of around 8,000 confirmed cases, while MERS killed 34% of the 2,500 people it infected. It's quite possible to imagine a future virus with a more wicked balance of virulence and transmissibility. These are the sorts of numbers we need to sit with and take ownership of if we're going to advocate for personal freedom and dignity over strict public health social measures. A valued perspective in this discussion came from Lorraine Finlay, who co-authored a sociological and legal retrospective titled Collateral Damage.
I'm currently the Human Rights Commissioner at the Australian Human Rights Commission.
I also welcomed Professor James McCaw from the Uni of Melbourne School of Population and Global Health. He's one of the computational modellers who contributed to Australia's national plan, a roadmap for easing of social restrictions as vaccine coverage increased.
And from around 2005 actually worked periodically on about 3 revisions to our health management plans for pandemic influenza.
Professor Catherine Bennett was the lead author of the Commonwealth Government's COVID-19 response inquiry, published in 2024.
My population-based research is really focused on transmission in community, but also antimicrobial resistance.
Finally, I was honoured to have the frank and fearless contribution of public health physician Professor Paul Kelly, who was Australia's Chief Medical Officer when the COVID-19 pandemic struck.
I found myself as a member of the Australian Health Protection Committee when I became ACT Chief Health Officer in 2011 and then transferred to the Commonwealth in 2019, just in time to be put in the hot seat.
For the purposes of this podcast, I wanted to try and understand which PHSM policies were individually more effective than others, and which might not have been worth the hardship. In Australia, 4 tiers of increasing severity were applied at various times, and there's a good representation of their cumulative effect in the National Plan. This modelling was commissioned by the Commonwealth Government to advise on use of non-pharmacological measures up to the point that herd immunity was reached. As discussed in the last episode, one way of expressing viral transmission rates mathematically is the R value. The basic reproduction number for the modelled variant of SARS-CoV-2 was 8 people infected for every new case. The aim of the game is to bring this number down, ideally below 1, to stop an exponential increase in case numbers. When the National Plan was published in August 2021, about half the population had received 1 dose of COVID vaccine, knocking the effective R value down by a couple of points. This is shown in the papers as a stacked bar chart, with another 4 points eliminated from the stack by introduction of baseline restrictions. This meant a cap on the density of people in indoor venues and a 70% capacity limit at large sporting venues. Always in the background, there was our contact tracing regime, or to give it its full name, Test, Trace, Isolate, Quarantine. The idea was that if you tested positive for COVID-19, then public health staff would interview you about all your movements and interactions over the previous week, and alert potential contacts to self-isolate. What were described in the model as low-level PHSMs required venues to keep records of entry and restrict seating density further. The model suggested this would bump effective R down by 0.3. Under medium-level restrictions, people were expected to work and study from home if they could, and concerts and non-essential travel were off the cards. This was predicted to reduce R by just 1/4 of a point, but in combination, all the above measures could get effective R below 1. That's if contact tracing was working optimally. This was very effective at stamping out embers while the caseload was low, but once there were hundreds of new cases a day, there just weren't enough personnel to follow up every single one. That's when high-level restrictions would have to be invoked to get you over the line. This includes the infamous hard lockdown, meaning that only workers from nominated industries were permitted to leave their house for work. People could go out for essential tasks like shopping or care work, but had to stay within a 10k or at times 5k radius. School education had to be entirely online, and outdoor exercise could only be done in pairs. The National Plan model also assumed implementation of nighttime curfews, which were used at various times in Melbourne, but not other cities. The tiers described in the model don't map in every detail to the stages 1 to 4 framework that you'll hear Professor Bennett refer to later in the context of Victoria. But that idea of an incremental impact on community transmission is what's important. The modelling showed, as you'd expect, that by the time you reached 80% of the population vaccinated, baseline density restrictions alone would be sufficient to stop the spread. For the first year of the pandemic, Australia maintained manageable levels of transmission without forced stay-at-home measures. But that all changed when the more transmissible Delta and Omicron variants hit our shores in 2021, particularly in the Victorian capital, Melbourne. It was argued by some that the hallowed target of herd immunity was better reached by natural inoculation. Let the virus rip through the community in one fell swoop, rather than putting millions of people through the burden of lockdowns. Later, I'll make some attempt to quantify the psychological impact of keeping people away from friends and loved ones, and even their schoolmates. But first, I asked Professor James McCord to explain how accurately those decrements in effective R that I described earlier reflected the known efficacy of different PHSMs.
So there's a few important things here. One, they're based around as much of the data and evidence we had at the time, but of course the pathogen was not static, it kept changing. And that's where the value of these modelings comes from. It wasn't the precise numbers, but it was actually the idea that as vaccine coverage increased, it allowed for reasoning on the benefits of maintaining the public movement restrictions, maintaining that system while the vaccine rolled out, such that when society was like freed up again and in that reopening strategy, that we wouldn't then have rampant spread of the pathogen, which would put us back into a problematic situation where hospitals were under stress, at the pointy end deaths that were avoidable were occurring.
That's a good point. Yeah, that the modelers don't claim to be savants, but it helps guide the policy. And
I think there were some modelers internationally and in Australia who were making that claim, unfortunately. They were suggesting that they could precisely predict the future. They could, build a model that was complicated and say that on this date the numbers would be this. And I think that's very poor science. That's my critique of broadly some people in this sort of community. There were lots of new ID epidemiologists, and there were people who came in who had the same technical skills as the group that I co-led with Jody, and a different group I co-led with Associate Professor Freya Shearer in my institute. But they didn't understand the value or the not value of modelling in terms of the decision-making process.
Well, all models are wrong, but some of them are useful. And despite all the argument over which model was better, Catherine, since the pandemic, there's been a lot of analysis over real numbers of infections and deaths and, trying to tease apart what real-world impact these various social restrictions had. I've tried to wade through the literature and it's quite messy. Have you got a sort of confident synthesis of that literature?
Yeah, look, I I think it was the ascendancy of modelling, and modelling's been used a lot to try and sort of unpack what worked and what didn't work since as well. Australia actually went on a different journey when it came to developing an immune history as a population, was very different to the rest of the world, or most of the rest of the world. And we implemented a lot of our early decisions under the precautionary principle. So, that's you don't wait for evidence, you do things that are likely to work and to do no harm. But I think we got very comfortable there. And I don't think, we were collecting all the data we needed, even to supply the modellers with what they needed in a concerted way, in a consistent way across jurisdictions, but also to evaluate what was working and what was not. So if you put things in place, particularly as significant as curtailing, people's liberties and movement, you really need, we can't do any public health without having an evaluation program built in. And we really needed that. And it would have generated really useful data to both refine what we were doing to make sure that we were minimising it to get maximum effect, and most importantly, to communicate that to the decision makers and to the community. So what we heard in the inquiry was that people were willing to go through restrictions again, including vaccination, drops off a bit for vaccination, but the majority of people would still be vaccinated again if they were given the evidence and it was communicated in a way that respected their ability, that gave it to them in an accessible way, but trusted them to actually make the right decision, because they did do it this time. I think we've got data that would allow us to know where outbreaks were occurring when we had restrictions in place, so where they were failing. We could potentially separate out what were additional controls that were about policing, the containment on movement, not necessarily health-based. I think it was presented to the community as they're all health-based, but things like having a curfew, you didn't change the allowance to go out and shop or do other things for an hour, exercise and so on, but you gave them a shorter time frame to do it in. So you actually push people together. So there were things that actually were counterintuitive epidemiologically that were all kind of packaged in together, because some of that was supporting the policing that was to minimise movement and contain. And finally, I just want to say one of our longest lockdown in Victoria of 112 days in the second wave, it was actually missed by most people that the vast majority, 2/3 of our cases, were either residents in aged care and workers or their immediate family contacts. So in fact, it's really hard to measure the impact, because for the majority of the population in Victoria, this was about keeping the dry grass watered, so that if a spark landed from aged care, it wasn't going to start another fire. So that's using very strict lockdown to manage risk rather than to control an outbreak. And internationally, the view is lockdown should be used as a control measure, not as a prevention measure. So, yeah.
So I'd really like to reiterate that in Victoria as well. And I wrote a piece in The Australian very, very strongly on this, where I was critical of the Victorian government and saying that because we actually had this data, there's this other part of my work which was very data-driven, and we had that information and we were putting it to government, that it wasn't, in my view, a necessary response to hold those lockdowns on for as long as they were. We took too long to start responding to that second wave in Victoria, and then it took too long to adapt. And I think that's not a revisionist understanding. That's actually what was understood in real time by many of us.
That's interesting.
And one thing I think that's worth adding here is that early on in the pandemic, when we had little understanding of the biology and the epidemiology and durations of requirement for quarantine, or the probability of the virus coming through, we, and I think justifiably, needed to take a precautionary approach. And then as we learnt more about the pathogen, having the ability to more rapidly adapt policy is something that I think will serve us well in the future. The characteristics of a new pathogen will be different, and we'll have to learn that again. But the key is to have a framework, a management plan that acknowledges the need for continual reassessment and therefore refinement of policy. And I think that will go a long way in helping us be brave and act early, and then adjust our responses to minimise the collateral harms that Lorraine and Catherine have both teased out.
And I think it's a truism as well, James, that our waves last 6 to 8 weeks, the main part of the peak. And often when something kicks off, you have to go in very early. So we then move to these very quick, short, sharp lockdowns, they would call them. And, when they were analysed, as James said, not every spark starts a fire or every cigarette butt. So, again, you need to learn from those to decide when you even put those in place. But for bigger responses, by the time you put things in place, you're probably reaching the peak. And so when things start coming down, then it's worked, But in fact, maybe not. And finally, in Victoria, we overlaid masks in the latter part of mid part of the second wave in Victoria. And so we had stage 3 and then we introduced masks. And when you looked at the glide path of the infection, it actually brought that back to about 1 pretty quickly in the time frame you'd expect within 2 weeks of masks. But they went to stage 4 before, because they just didn't feel they could wait for those results to come through. And so even when that happened, they didn't use that to say, well, okay, actually we can pull back, because stage 4 would have a lag time because infections, take a week or 2 to be to present and then be recorded. But, we just sort of kept on going, whereas New Zealand actually contracted their interventions, made them more focused when they figured out what worked. So I do think we tended to expand and then back that up with fear messaging to try and drive it home, which then made it very difficult to pull back from that because you'd sort of painted yourself into a corner.
The findings that Professor Bennett is talking about came from a cross-sectional study of Melbourne's Delta wave in mid-2021 and are published in the journal PLOS One. On July 23rd, a mandate for mask wearing in public places was implemented 2 weeks after a soft lockdown had already been declared. This gave researchers a unique opportunity to analyse the impact of the mask policy in its own right. Case numbers had been almost doubling every 16.5 days until they turned a corner with the introduction of the mask mandate, even before stage 4 restrictions were imposed on the 5th of August. Another Canadian study found a similar impact on growth rate of cases in Ontario that wasn't seen in comparable provinces which didn't introduce a mask-wearing policy. And there's an interesting case control study conducted over 2022 in California. Almost 2,000 residents were recruited after receiving a COVID lab result on the condition that they hadn't had a known case contact in the previous fortnight, but had spent time in indoor public settings. When asked about their mask-wearing habits, those who claimed to have always worn a surgical mask indoors were a third as likely to have received a SARS-positive lab result as those that never did. For those who specified use of an N95 mask, the adjusted odds ratio was just 0.17. The authors of the Australian study did give the caveat that their findings didn't necessarily say anything about the physical efficacy of masks. It could just be that wearing masks or seeing them around makes people more conscious of other social distancing and hygiene measures. Now, none of the observational findings I've described were included in a 2023 Cochrane review, which looked at a dozen randomised control trials of mask use in real-world settings. There were 250,000 participants captured in this meta-analysis from settings as diverse as university dorms during the US flu season, tents full of pilgrims congregated for the Hajj in Mecca, and Bangladeshi villages over the COVID-19 pandemic. The authors concluded that people assigned surgical masks were only marginally less likely to get diagnosed with influenza or COVID-19 than those who were not. While these findings were leapt upon by libertarians opposed to masks, it was never mentioned that the Cochrane authors raised concern about the low or unreported levels of adherence to the intervention, and poor blinding of outcome assessment. Early on in the pandemic, there was some confusing messaging about masks, even from the World Health Organization and the US Surgeon General. And there was defensible concern over maintaining sufficient supply for health workers most at risk. Way back in episode 73, I also explained the origins of the mistaken dogma that respiratory infections were transmitted only in heavy droplets of spittle. When the record was corrected with an understanding that SARS-CoV-2 was capable of aerosol transmission, the haters suddenly had science on their side. Take, for example, veteran News Corp journalist Adam Creighton, who tweeted, quote, "Imagine having an IQ above 90 and thinking mask mandates stop viruses, just like barbed wire keeps out mozzies." But of course, science is never that simple. Yes, it's true that surgical masks have pores that are a few times larger than the smallest SARS or influenza aerosols. But masks also restrict airflow and have electrostatic properties that can trap particles. Australian lab experiments have shown that if you cough into a petri dish while sick with the flu, a mask will prevent viral DNA from being detected on the dish. We know that not everyone will take the advice to wear masks, or wear them properly, so further research and public education would certainly be informative. But it does seem plausible that better adherence to mask advisories and basic social distancing could have obviated the need for stay-at-home orders in some instances. Perversely, however, the same people who were most opposed to draconian lockdowns also didn't want to have anything to do with so-called face nappies. The Human Rights Commission reported that a quarter of 3,000 Australians surveyed thought that people should have a right to refuse to wear a mask. Lorraine Finlay and colleagues did receive, in open submissions, legitimate and perhaps intractable concerns from people reliant on lip reading, who were gravely impaired in their ability to communicate in public as a result of face masks. Public health is messy. Even with the best of intentions, every intervention will disadvantage some community somewhere. And the messaging has to be simple. Yes, there were some silly rules about wearing a mask, even when you were at the park with a friend, but introduce too many caveats and people get confused. In fact, one of the most commonly heard sentiments over the pandemic was that people just couldn't keep up with the ever-changing advice. Catherine Bennett and Paul Kelly pick up from here with some general comments about how much we still don't know about these behavioural problems, as well as the epidemiological ones.
The data we have, like in Victoria, collected in that second wave, particularly by the end of it, we went out to the second ring of contacts, so we could actually see how the virus tracked through those close contact circles. Incredibly valuable, but it's all kind of long text. We don't have the data in a way that we can start doing some really smart analysis. That there is this opportunity to start to unpack some of that in a more detailed level. So when you come back to, did curfew work? Well, how many outbreaks were seeded from events where we know that someone was breaching curfew? If it's none, then why have curfew? If it's not happening in that part of the community, if it was still being seeded out of aged care, we may never know what worked because it wasn't tested. There weren't, that there wasn't the virus going through the community to show where there were gaps in the policies or the orders in place at the time. So I do think there's more to be learnt, but I don't think we'll ever have the complete answer.
Paul, you wanted to add something?
Oh, look, so much to back there. Firstly, two Victorians talking. Victoria had a very different pandemic to Western Australia, for example, where I've been doing a bit of work over the last month. They tell us on one side, the pandemic was terrible, but then they actually had 2.5 years with not a single case in the community. So they didn't have a pandemic, really. Couple of things I'll pick up on there. One is, James, great insight into what models are and what they're not. Put that into a political sphere, and then the way they were used at the time was, sometimes quite disturbing. They were definitely seen as a crystal ball. The other thing that was happening there's another hindsight bias issue is all Australian governments were captured by the eliminationists at that time. This idea that we just needed to get rid of that very last case, we had to find that last case, and we couldn't lift any restrictions until that last case was found and got better and was not transmitting. And that's just rubbish. That was never going to be the case, that we would just magically never have COVID in Australia. New Zealand was worse, but that was certainly an issue. So what that led to, many of the things that have been talked about, it comes back to proportionality again. We did too much for too long through the pandemic. I think for some things we were quick, others not so much, but it was complicated at the early stages of that second wave in Victoria. I was part of those conversations. Partly because we had very little understanding about how our cities work, certainly at that political sphere. So there was these ideas we could have hot spots. Remember hot spots?
Yeah, it never made any sense.
No, it was totally ridiculous.
For the benefit of listeners outside Australia, hotspots were sometimes declared around postcodes if there had been a steep increase in case numbers among residents. These postcodes could then be subjected to selective stay-at-home orders, which my guests explained by email were just guided by the political motivation to minimise social and economic disruption. But there's no realistic way to geographically contain a highly transmissible virus in an immune-naive population, and the hotspots were always swiftly followed by citywide lockdowns. The most egregious example of this took place in July 2020, in housing tenements in the northern suburbs of Melbourne. These 9 buildings were home to a total of 3,000 people, many of them not native English speakers. With very little warning, hundreds of police showed up to prevent people from leaving, before residents even had time to stock up on groceries. Food was brought in by health personnel as the lockdown lasted several days, but the Victorian Ombudsman later found that the lockdown violated state human rights law and ordered the government to pay $5 million in compensation to those affected. Another point relevant to the conversation ahead is that we outright banned visits to aged care residences until vaccines had been widely administered. That's because more than a third of all Australian deaths up to 2023 occurred in that setting, mostly in private facilities with poor standards for staff numbers and professionalism. All right, back to Paul Kelly.
It's totally ridiculous. All aged care workers, low-paid and insecure jobs, live in the poorer suburbs of Melbourne. They work wherever they work. And because they were an essential industry, they were able to go to work. So, of course, it spread. And so hotspots made no difference. Brett Sutton, the Chief Health Officer in Victoria, at one point talked about the colander of steel around Melbourne. It was one of the better quotes of the pandemic, I think. It was leaky. But the public health orders in the states have to be black and white because they're enforced as laws by police. And then the other thing, for the fairness factor, regardless of what James was saying, that most people did the right thing, there was any sense at that in those early days in particular that we're all doing the right thing, but that person over there is not doing it. They need to be punished or prevented by a law. That was a very strong narrative through that time. We know that these things work, though. It's a respiratory virus. If you lock everyone up in their house, as happened in other countries, for 2 weeks, you get rid of it, until it comes back again. But that's, we saw that in China, we saw that in Vietnam, many other centralised countries. And the lockdowns, whilst they were very severe, even at stage 4 in Victoria, they weren't that. So there's gradations of what is acceptable to the community from there, and that comes back to your original premise there, Mick. A lot of it's about introducing things that are acceptable as well as work. And I really like the Singapore approach that they've put together in their new communicable disease agency, where they describe it as Lego. So they've got their pieces of Lego. It would be masks, it would be border closure, it would be various other public health and social measures, and then add vaccine, which of course we didn't have at the time. And they had that and communicate with the public that these are the sort of things that we might use, but it will depend on what the virus is, much more than this kind of levels approach. I think that was too restrictive.
Mm-hmm. Catherine, you want to add something?
I also just want to make the point, which I think it's relevant here, is that in public health, we never expect 100% compliance, and you don't need it. You won't vaccinate everybody, and it won't be 100% efficacious. And likewise with masks and other things, if someone's infectious and they don't wear a mask, that is a greater risk to other people. But at the same time, if they're wearing masks, or most are, it reduces the chance of that transmission event. What you're doing is you're kind of disrupting that transmission potential. So I do think that's important, because you can spend a lot of time focusing on trying to convert people who are unconvertible to actually comply, and it makes it punitive and negative and so on, rather than kind of reinforcing we're doing okay. I remember in Sydney when they had to keep extending their Delta outbreak cautionary measures and lockdowns. And I was asked to contribute a piece to The Guardian, I think initially, and it was followed up the next day by the Sydney Morning Herald, to talk about what was working, because they had maintained an effective reproductive number in Sydney of 1.3 when it was Delta. It was 8, if it was sort of uncontrolled or thereabouts. And so it was working. So they were still seeing more cases, but nothing like they would have seen if they didn't have these precautions in place.
Yeah.
And no one was talking about that. They were all talking about why numbers were still rising and that not everyone was complying and so on. But in fact, it was a story of extraordinary control. Victoria was a month behind in that wave. That started a month later in Victoria. And the media were focused on, well, Victoria's doing better and they've got more strict lockdowns. We need stricter lockdowns here. Victoria never achieved the same level of control in that Delta wave that New South Wales did. By the time they were caught up in the 30 days and you line them up epi-week aligned, they were always behind New South Wales. Now, that was probably because there was more fatigue. They'd had the second wave in Victoria prior to that. They'd lost some of that community buy-in. So it wasn't just about the measures, but it certainly wasn't just about ramping up the measures. It was clear information about what was working, from measures to immunity. That was the way out. That's where we were going. And some of the quotes from the pieces I wrote in the weekend were used by premiers the following Monday. And I think that was really telling, that we were helping people understand what's working, how it's working, and how we're constantly analysing it. So we're not asking them to do things that are ineffective, but we're also focusing and doubling down on the things that are, and bringing them with us so they know why. They got that and they needed it. And I do think that's where we can do a lot better next time, and it will give people agency, and that's what we try and do in public health.
When the sixth period of stay-at-home orders in Melbourne ended in October 2021, it was described as being the most locked-down city in the world, having tallied up 262 days of Stage 4 restrictions. I wanted to understand whether the sacrifices Australians made over that period could be justified, at least in terms of epidemiological control, or whether the cure was deadlier than the disease, as predicted by some commentators. I vainly thought I was going to come up with a synthesis of the evidence more comprehensive than any before it, and that the numbers would not lie. That I'd be able to calculate the cost of PHSMs in some health economist's best guess of QALYs lost, and then weigh that against the lives that would have been sacrificed had society remained more open. But there are just so many variables to tally up when considering excess morbidity attributed to the social restrictions. And there definitely were interruptions to routine healthcare. In a synopsis for the NH&MRC, it's reported that up to June 2022 there were 345 excess deaths from heart attack, strokes and heart disease that would have been avoided by regular checkups. There was a roughly 8% reduction in cancer-related diagnostic and therapeutic procedures, and delays in screening may have resulted in 90 deaths. Each one of these deaths is certainly a tragedy for the family involved, but the numbers we're talking about are orders of magnitude smaller than the COVID-related deaths that were averted under these policy settings. It's also worth noting that in countries like the UK, where COVID-19 was not being suppressed so aggressively, there were high levels of healthcare avoidance, and evidence that patients who attended ED departments for presentations other than COVID had poorer health outcomes than normal, simply because care was stretched so thin. The more hefty argument against lockdowns and other social restrictions relates to the psychological morbidity associated with curtailed freedom of movement and human interaction. A well-rounded systematic review of population surveys is the 2024 Lancet Psychiatry Commission on Youth Mental Health, which highlights interacting risks and also protective factors from different health systems around the world. The Uni of Melbourne's Professor Patrick McGorry was the first of more than 50 authors, and to get a little deeper, I pulled out 2 of the reviewed studies that were conducted in Australian settings using robust datasets. One 2022 paper from researchers at the ANU reported findings from a survey of 3,500 Australians. Yes, psychological distress spiked with the onset of the pandemic, and yes, it correlated to an increase in self-reported loneliness. But scores returned to pre-pandemic levels as social restrictions ended by the end of 2022, and this was not the only paper that identified such a correction. Another Australian study published in the Lancet Public Health is described by its authors as the world's first analysis on the effect of stay-at-home orders independent of other confounding drivers. They used data from the very large longitudinal HILDA survey, which includes assessments on the mental health inventory. The study took a quasi-experimental design to compare Victorians who had experienced lockdowns in 2020 to people in other states who had not. This comparison showed a small but significant deficit of 1.4 points on the MHI scale, which the authors describe as clinically relevant and, quote, equivalent to that of major life events such as being laid off from work, end quote. Across the population, this meant an additional 2.6% of people being likely to test positive for a mental health disorder. Interestingly, the overall mental health impact of lockdowns was not driven by the populations that would have been considered most vulnerable a priori. Adolescents between the ages of 15 to 19, older adults living on their own, or those with chronic physical or mental health conditions. The message I take from all these data is not that lockdowns were harmless, but that they might not have been quite as heavy a cross as we expected them to be at the time. I drew the same conclusion when looking at findings around the effect of school closures on the educational progress of some 4 million children in Australia. Our strict policies meant that teaching had to be delivered online for periods ranging up to 36 weeks in Victoria. Much has been made of the increasing rates of school refusal by Australian teenagers, though that trend was already on the way up even before the pandemic. And it's no lower in Western Australia, where they only had 3 weeks of school closures. According to an early forecast by UNSW Professor of Economics Gigi Foster, the disruptions to classroom teaching would result in a deficit on lifetime earnings, adding to billions of dollars, and was, quote, tantamount to a ritualistic human sacrifice. While we can't predict the future, we can retrospectively evaluate the educational attainment of students on the National Standardised Assessments in Literacy and Numeracy that take place every year, known as NAPLAN. An analysis of these acquired during the pandemic shows comparable scores to those of students undertaking the tests in 2019. The study authors from the University of Sydney and UNSW used regional variations in lockdown in a sort of dose-response analysis and found a small but insignificant relationship. There was also no significant increase in the number of students failing to meet minimum standards. Some other analyses of these datasets indicate that, with the exception of Indigenous students and those from non-English speaking households, socioeconomically disadvantaged cohorts were not disproportionately affected. The final point in this calculus is, of course, whether school closures actually did much to reduce community transmission of SARS-CoV-2. In one meta-analysis looking across 178 countries, it was concluded that from 18 interventions, quote, only school closures and internal movement restrictions showed unequivocal evidence of being associated with a decrease in effective R regardless of the assumptions made, end quote. But also take note of the prospective case-based research conducted across almost 9,000 schools and daycare centres in New South Wales. They found that even for variants of concern, outbreaks within schools seemed to track community transmission, but were not a driver of it. One of the research leads, paediatrician and ID specialist Archana Koirala, told media that this was surprising given what we know about the transmissibility of influenza in the young. Infants in particular are vulnerable to pandemic influenzas because they don't have an immune memory against seasonal variants. In 1957 and 1968, two closely related N2 influenzas emerged out of southern China that killed between 1 and 4 million people. As a proportion of the world's population, they were about half as lethal as COVID-19. But 45% of excess deaths were in the under 5 age group, and another quarter comprised everyone else up to the age of 65. The first pandemic in this century was the 2009 H1N1 swine flu. While it killed no more than 500,000 people around the world, the median age of death was just 53. I wonder if the libertarian pundits would be so keen to let it rip with a virus that kills infants and people in their prime as they were with one that preyed largely on the old. I don't quite know how to synthesise all the information I've dumped on you. Future governments will certainly be more squeamish about reaching for levers like lockdowns and school closures, but they shouldn't rule them out. While journos like Adam Creighton described the public health response to COVID-19 as the great insanity, it's rhetorically unconvincing to catastrophise the outcomes of the intervention in trying to argue that we catastrophise the threat of the virus itself. In the 2 hours I had with my interview panel, I didn't get the chance to put all these thoughts to them. But they all expressed that we need a better appreciation of the qualitative outcomes in public health. Take, for example, the final year students who recently told the ABC that they'd lost social confidence as a result of the disruptions to their early years of high school. And quite apart from academic results, some felt they'd been denied the chance to progress in sports or the performance arts. Faced with these unquantifiable factors, I came to understand why my guests felt it wasn't the role of technocrats to make such consequential value judgments, but politicians elected to represent the public sentiment. Here's Lorraine Finlay to add some final thoughts on this theme.
Could I just make one very quick point? And we've had a really good conversation about data and modelling and what we can know and the numbers and how it can guide policy making. That's all critical, but the real nub of the issue in relation to lockdown is that the numbers can't capture, no data can capture the cost of what was lost by people. We can measure the lives that we think we've saved, we can measure the public health impacts that we think we've had, but in terms of the things that people lost through lockdowns, be that the separation from loved ones, missing the birth of a child, missing the funeral of a relative, you can't ever get those things back and you can't put a cost on them. And I think the idea that we were just throwing everything we possibly could at this to try to get those numbers down or flatten the curve or whatever it was, I don't think there's been enough acknowledgement of the fact that that had such significant impacts on people, and those impacts that can't be measured by data. And to me, that's really the heart of the lockdown issue, that really it was the things that make our lives worth living, the things that make us human, that are things that are taken away from you when you're locked down. And again, there might be very good reason for that, but I still don't think there's been a proper acknowledgement of those costs.
I couldn't agree more, Lorraine. And those considerations, I hope this doesn't sound defensive because I don't think it is, those considerations, they were enormous in the discussions about should we or should we not be making recommendations to government on these things. That tension, you didn't know what it would be. You knew it would be a negative impact and that you could never measure it. Loomed large in every conversation about what would be a recommendation or an appropriate public health response or not. And being able to communicate that awful kind of trade-off that you could never really work through was a big part of our Australian decision-making process. This reminds me of a really pertinent relative risk discussion, would have been in mid-February or early March 2020. Sitting around the table with the chief health officers and Paul and others. This was at AHPPC. And we were trying to figure out if we instituted certain interventions that would restrict or modify people's access to other health services. We were trying to think through what would be perhaps a drop in breast screening attendance. And so in 15 years or 20 years, how many more extra deaths due to breast cancer may we expect? And it was a real conundrum, how do we try and understand the downstream implications? And these are calculations one can imagine, but you can't actually put numerical values on all of these different points. No one knew in March 2020 how long it would go, how many women would change their behaviour or change access to getting the screening and so on and so forth. So things like that were large on our minds. Paul, you'll remember these sorts of discussions.
Well, I'm conscious that there are 5 minutes left of the time allotted to talk about school closures and the psychological harm, and there have been attempts to quantify that, increases in mental health presentations. There was the concerns over increases in domestic violence. And I'm trying to pack everything into one question here. Lorraine, you discussed a lot of this very well in the report. So can you speak to some of the rights that you would argue for, legal rights that would cause pause for thought the next time considering these interventions?
What makes this such a challenging issue is there is a direct conflict of rights. I mean, the right to life is a core human right, but then also the right to movement, the right to family life, the right to privacy. There are a whole range of human rights that come into play here, all of which were conflicting with each other, and that's before you even get to the question of individual rights versus broader community rights. And so I think the core of this is to recognise there are no perfect answers. When you're dealing with something like this, first of all, even in a perfect world with perfect information, there's never going to be a perfect answer that doesn't involve some adjustment or compromises when it comes to trading off human rights in particular ways. But then in an emergency, you're dealing with an imperfect situation where you don't have perfect information, you don't have the time to make these decisions in a consultative, lengthy process. You don't have the benefit of hindsight. So, I think the only way you can deal with these types of things is to actually do a lot of that work ahead of time and to build human rights analysis into your planning and your preparation to make sure that, as James was saying, when you're having these discussions around public health responses, human rights is front of mind, but it's also communicated to people that it's front of mind, so that even when people are forced to comply with decisions that they may not individually agree with, they understand what the thinking was behind them and they understand why those decisions have been put in place. And in a response, hopefully, that learns from the pandemic, we'd have a framework that not only builds human rights in, but that also builds humanity into the responses in terms of ensuring that you do have those fair and compassionate exemption pathways, that you do have a recognition that one size doesn't fit all. In this particular pandemic, it really was the most disadvantaged amongst us who in many cases were asked to bear the biggest burden. So actually putting in some of those considerations around equity into our responses. I think there is a lot that Australia got right, and I don't want to leave this conversation without acknowledging that. There is a lot that we did that we should be really proud of, and a lot of really positive leadership that was shown. But gosh, there are a lot of lessons that we also have to learn, and we really want to do better next time. And we recognise that while we did get things right, there was a really significant erosion of trust and residual anger amongst people who don't feel as though their needs were taken into account and who do feel as though they were collateral damage.
Well, your report was really interesting in that way, in that the surveys revealed that 3/4 of the Australians surveyed were largely on board with the policies. They agreed that individuals might have to give up certain rights for the broader community safety. But then the individual submissions were just so raw and so powerful. And I think it really depended on, we've already talked about this, one's individual experience of the pandemic. So we do have to recognise that 90% of COVID deaths in Australia were people over the age of 70. So I suspect that people whose elders did make it through the pandemic might focus more on the deprivations that they were forced to undergo, the isolation, whereas people whose parents or grandparents died because of a breach in containment might see this as an avoidable death that was due to negligence. So, Paul, have we had? I don't think we've had a grown-up conversation about what value we attribute to dignity versus life at all costs, and what loss of life would we be prepared to accept next time round to preserve some of that dignity.
This comes to ethics and a very complex conversation that we do need to have, and I agree with Lorraine. When I read the report, I just thought it was so wonderful to see the depth. The irony of all this, of course, about taking human rights perspectives into account is, we've been talking a lot about Victoria. Victoria is a human rights compliant state. It has specific laws from their parliament that says that any decision of government must take into account human rights. But that's the challenge. Having that as law is not the answer. It needs to be something about attitude and explicit in the planning and the response. In the way that James has already mentioned, that we of course took all of this into account every time we met, and it was 583 times, I think, over 3 years the AHPPC met. We were given the task, save lives at all costs. That was our role. What can you advise us to do to save lives in Australia? It wasn't, can you just make sure that you think about school performance in 10 years' time and all that? That wasn't there. But inherently it was. We were all, all of us around that table were thinking about those things. But that was the task that was given, and that was the answer. And, more than once I was asked by my political masters to get back in my box and stop talking about society. They know society. Just give me the medical information.
Swim lanes, not boxes, Paul, if I remember.
That was a big one.
Swim lanes, exactly. Swim lanes was used a lot. And I'm a swimmer, so I understand it. So I think all of those things are absolutely crucial for us next time. And there will be a next time. It will be, we'll have similarities, as Mark Twain famously said, history doesn't repeat itself, but it often rhymes. And we can do as much planning as we like. Ultimately, to quote another author, Mike Tyson, so Mike Tyson very famously says, the plan is only good until the first punch in the face.
I think Napoleon said something similar about war.
Napoleon said something similar, and Eisenhower said something similar too. Anyway, the point is, you can plan as much as you like, but ultimately there will be some things that will be the same, and other things will be different. So agility, being able to get the sort of amazing people that were around the table, trying to decide with the information at the time, and hindsight bias, it does tend to oversell that, how much we knew at the time. We knew very little about this virus early on, and it continued to surprise us. But that's not an excuse not to plan, because that's how you get people around the table, but also to have that wider view that Lorraine has so well spoken about.
I just want to, pick up on the point, as Paul said, we can't anticipate everything that's going to happen. And in research, we were doing emergency funding for really focused research on critical policy relevant questions or basic science that we needed to understand the virus. But they could get approval and then wait 6 months to get ethics approval, to actually use the funds. And so we need to have things that we've thought through and are sitting on the shelf that we can then activate that recognise a shift in risk and manage the ethical process in a more expedited way without compromising individual rights and so on. And I do think the other thing that has come through here is the difference between individual rights and community or population rights. And a lot of that does sit in the analysis, in having evidence that actually asking someone to do something is not just about them, it's about the broader community risk. We think the very young and the very old from the inquiry were the ones most impacted in our response to the pandemic, and particularly the elderly, as you said, Mick, have the impact of deaths both in the pandemic itself and since. But at the end of the day, we did take away individual choice in our elderly. If they were in a setting where they could see family and it wasn't a risk to other people, we didn't give them that choice by actually putting these blanket rules in place. And I think there's some of the areas, that difference between your risk to self and risk to others, you should have a different level of agency in some of those decisions. And, even around the vaccine in those situations where it wasn't about onward transmission. So I do think they're the complexities we need to think through. We need to have the difficult and philosophical conversations about whether it's life at all costs and what that looks like. How much do we compromise education at a young and socialising in our young for what may be only a year or two's life in the elderly? That was really tricky. And you couldn't actually do that conversation in the midst of a pandemic. We need to be doing that now so that the community is brought along before we face a crisis like this again.
There's also the other side of that argument where we now know that these social restrictions eliminated almost all deaths from seasonal flu among the elderly. Every year there are several hundred deaths directly attributed to influenza and a couple thousand deaths precipitated by flu. Does that put an onus on us to do a little bit more, at least wear masks each season to reduce that?
Well, is it masks, or was it that we didn't see new variants into the country because if the people that did come in were at border control?
There was very minimal transmission of the virus itself. So
that's true, but it probably peters out after you've had a wave when you build immunity to the circulating strains. And if you don't introduce the next season's strains, it's untested.
Should we close all borders every flu season?
I feel like I have to just put on the record an objection to that.
Exactly, Lorraine. This makes no sense to any of us.
I think that's a pretty good place to end for the moment, and you guys have been incredibly generous with your time. Before I go, I just want to share some further nuggets I wasn't able to cram in earlier. Many commentators have argued about the folly of public health measures that restricted people's livelihoods and economic prosperity of the country as a whole. If you go back to podcast episode 72, you can hear me discuss some analysis suggesting that as measured by relative change in GDP, countries that acted with a stronger public health response had better economic performance than those that took a more lax approach. Similarly, there was little difference in the relative scale of Australia's government-funded job subsidy program and the bailouts seen in the USA, Sweden and Germany. I'm sure there's plenty of conflicting literature I've missed, and my point is simply that there's no open and shut case in either direction, whether we're talking economics or epidemiology. There are so many unknowns and so much dependence on context. Have a think about the H5N1 influenza strain that has kept researchers awake since 2003. While we call it the bird flu, it can now be transmitted between cows and even seals, large numbers of which are now dying with devastating respiratory and neurological symptoms in and around the Antarctic. So far, it hasn't been transmitted between people, so there have been fewer than 1,000 confirmed cases, mostly among rural inhabitants of Southeast Asia. But the mortality rate amongst these has been 48%, which is just another red flag that future pandemics could force much more difficult decisions from society than the last one did. Influenza is obviously closely surveilled, and we keep a close eye on poultry stocks for economic reasons. But the species jump that gave us COVID-19 was a complete surprise. At an emerging diseases conference I attended last year, some presenters joked about humans being the sentinel species. That was hosted by the Australasian Society for Infectious Diseases, who will be collaborating with Pomegranate Health to bring you some expert content. The first episode to be released very soon will actually be addressing vaccine hesitancy. Many thanks to Profs Catherine Bennett, James McCaw and Paul Kelly, and Human Rights Commissioner Lorraine Finlay for their wonderful contributions to this podcast. And thanks as always to the physicians on the podcast editorial group who reviewed drafts of this story. They are Drs. Rahul Barmanrai, Zach Fuller, Aidan Tan, Mansi Arora, Joseph Lee and Funuala Fagan. For academic citations supporting almost every detail discussed today, please go to the website racp.eu.au/podcast, then click on episode 145. There, you can also sign up to an email alerts list for newly published episodes, although it's much easier to stay tuned with a pod browsing app. Just go in and search for Pomegranate Health, and do the same with your colleague's phone while you're at it. If you've got any feedback or suggestions, send an email to podcast@racp.edu.au. I'd love to know where the recent surge of listeners has come from, so please tell me where you came across the show. This podcast was recorded on the lands of the Gadigal clans of the Eora Nation. I pay respect to their custodianship over tens of thousands of years. I'm Mick Kabazzini. Thanks for listening.